Hello everyone. Now that we've already seen how to manage bileaf foot mitral valve disease using advanced techniques, even sliding valvuloplasty, now we want to talk about a situation that's fairly common. Patients often don't present with isolated mitral valve disease. They often present sometimes late in their course, and they have concomitant tricuspid valve regurgitation as well as atrial fibrillation. We know that managing atrial fibrillation improves survival and improves quality of life. So now let's see how to approach mitral valve repair, tricuspid valve repair, and even performing biatrial Cox-Maze.
Now, it is common when patients present with severe mitral valve disease, they have concomitant pathologies such as severe tricuspid insufficiency or atrial fibrillation due to late presentation. This is a 65-year-old patient who presented with long-standing flail posterior leaflet with severe mitral insufficiency, who presented in cardiogenic shock due to atrial fibrillation with rapid ventricular response and decompensated with severe tricuspid insufficiency. After preparation with diuretics and inotropes and cardioversion, he was prepared for robotic mitral valve surgery in the same admission. A Cox-Maze procedure was first performed, as you can see, and as we've done previously in previous episodes. Epicardial coronary sinus lesion, the left-sided lesions, the tricuspid completion line through the right, and the SVC line, right atrial appendage line, followed by the IVC line. Robotic surgery is not limited to elective cases once the learning curve is crested. This illustrates the completion of the left atrial appendage obliteration with a homogeneous closure. And now this patient's mitral repair is relatively straightforward, as it is a focal posterior flail and likely isolated just to P2. So a focal triangular resection is performed as we've illustrated previously. And once completed, in this case, semi-rigid annuloplasty band was utilized, as there was some remodeling. This is a 34 millimeter posterior band. Now, many have said that tricuspid valve surgery can't be done robotically. I think that is not accurate. It's actually quite straightforward. This is a tricuspid annuloplasty that is done with interrupted sutures, as we would do in open surgery, as it's right there in front of you and very easily doable with good result of absence of residual insufficiency. This patient went on to do very well. Another example of nearly an identical situation, except the patient was not in shock, but developed significant tricuspid insufficiency as well as atrial fibrillation. And cross-clamp is applied, antegrade cardioplegia is delivered, a patent foramen ovale that was identified by intraoperative T is easily closed. But in this case, you can see that there is some mitral annular calcification, or MAC, noted in the P1 area from the posterior medial trigone to close to the base of P2. A biatrial Cox-Maze is being performed, as you can see, is quite routine, as we've demonstrated in the previous case and multiple cases before. And this illustrates that we have to address atrial fibrillation at any time patients present. This is the one time we can help alter the course of their lives by helping treat atrial fibrillation. Vertical atriotomy, tricuspid completion line, the posterior and lateral SVC line, followed by the parallel right atrial appendage line, leaving the mid-right atrial body intact, and the low posterior IVC line. Again, no snaring with good vacuum assistance in the placement of the appropriate cannulas. Allows for excellent bloodless field. Now we go back and address the left atrial appendage, as we have demonstrated previously, with the two-layer obliteration and essentially left atrial plication. And now I'm managing this patient with fairly significant flail, but also the MAC we must avoid. While we can be aggressive and excise the MAC, we didn't feel it was necessary here because we have access to the full lesion. And in this case, we'll do a triangular resection, but a bit of a folding plasty, still a triangular resection, but a way to avoid the valvotomy getting close to that MAC. So we'll make it somewhat tangential, as that also is where the leaflets and the pathology seem to dictate. Mobilizing the restricted cords, closing a small cleft between P2 and P1. These little elements are very important to make sure we don't have residual pathology. So analysis is so very important. It follows the principles of mitral surgery. In this case, I'm just debulking the myxomatous leaflet and the abnormal pathology cord. And now using the cleft closure they already have performed, we're bringing that leaflet back over. Testing, of course, to confirm that following the valvuloplasty, we have good coaptation. As I've said previously in other videos, it's important to test in multiple times just to make sure we have good alignment and you've got good coaptation depth, that you know that you're on the right track. And now we've done this, while we could do a little bit more posterior leaflet height reduction, I think this is sufficient, particularly given the MAC. We're doing the anterior leaflet secondary and tertiary cord cutting to facilitate coaptation a little further. At this point, the patient had a little cleft in the anterior leaflet, so I'm just doing a small little cleft repair. And now we have good competence and final repair. Place the LV vent through the valve to get ready for closure. This is an example of how we can get excellent drainage with that multi-stage venous cannula by just placing it down to the base and slipping it up the SVC, as long as the SVC cannula is pulled back sufficiently when implanted. You have excellent exposure robotically, and placement of the sutures can be done quite seamlessly. Some have asked me in the past of why not do this on a beating heart. Well, you absolutely could do that, but an extra 15 minutes in this approach, I think, is well worth the precision and clear visualization. Weaning from cardiopulmonary bypass, no residual mitral insufficiency or tricuspid insufficiency with sinus rhythm.
So in our next season, we're going to talk about what happens when we're now faced with patients with type 3 disease. Now, these are more complicated because of restriction. And how do we manage restrictive pathology, be it standalone type 3 disease, A or B, or when it's combined or mixed disease with type 2 or excess leaflet motion? Join us then.